But also, like, literally how? You were an academic doctor. Did you, like, fill out an application form? Did
Yeah,
somebody tap
I
you?
did.
Really? Is that what
I
happened?
filled out an application form. Yep. And
No way.
Yep.
It's a paradoxical time to be in women's health. On one hand, there's more political energy than I can remember seeing in a while. At the beginning of the Trump administration, there was an executive order to make IVF more accessible. And since then, there have been moves to lower the cost of drug prices, to make fertility benefits easier for employers to implement. We took away the black box warning for hormone replacement therapy, which was something that the evidence has supported and that many people have advocated for a long time. On the other hand, the US still has the highest maternal mortality rate of any wealthy country. Rural hospitals are closing down their services, and we have a patchwork of state laws that are all over the place and create uncertainty for people who need services on the ground. To some degree, we all live with this intersection. My guest today's job is to grapple with those contradictions every day. Dr. Dorothy Fink leads the Office on Women's Health on behalf of our federal government. She brings a clinician's eye to one of the most complicated policy landscapes in medicine right now. I'm Dr. Neel Shah. Welcome to the Preprint. Dr. Dorothy Fink is an endocrinologist and a federal health official who serves as Principal Deputy Assistant Secretary for Health and as Director of the Office on Women's Health at the U.S. Department of Health and Human Services. She's also served as Acting U.S. Secretary of Health and Human Services in early 2025 as we were waiting for RFK Jr. to get confirmed. Dr. Fink is a board-certified internal medicine, pediatrics, and endocrinology doc, and she's a scientific expert in women's health, metabolism, and chronic illness. She trained at some of the best academic medical centers in the United States, and she went on to this illustrious academic career. But then, as she told me, she was inspired to apply for a job in the federal bureaucracy, literally filling out an application form because she felt compelled to serve and compelled to challenge dogma. Dr. Fink, thank you so much for taking the time to talk with us.
It's great to be here with you today.
You have a very broad role in the federal government, and I'm interested in the agenda that you're responsible for driving, Dr. Fink, but I'm equally interested in your perspective as a clinician scientist and how that perspective informs how you're driving that agenda. Well, maybe just to start, I mean, you've had an extraordinary career trajectory. So you, I think, did undergrad in medical school at Georgetown, is that right?
Yes.
And then you did a combined medicine pediatrics residency, which is not for the faint of heart.
It was a great, amazing years in Pittsburgh. Yeah.
Yeah. And I feel like the folks who do that, it's sort of like, why not do everything?
Exactly.
Right.
Cover the whole lifespan.
Yeah. And then you had postdoctoral training through the NIH program and also a fellowship in endocrinology. And then you became a federal official in a part of our government that is among the most wonkish and bureaucratically complex and consequential. But my first question is, how did that happen?
In the medical life, you never really plan it. And I never would have imagined myself here at HHS. Of course, I love my DC days during college and medical school, but I didn't necessarily have it in my plan to come back here. You know, during my years in New York, after I trained in endocrinology and was working, you know, you just come across so many aspects of medicine and you find yourself in positions where you think, how can I impact this healthcare on a larger scale? And when you think about some of the areas that we're really focused in on now, such as infertility, you know, as an endocrinologist, a lot of people think, you are an expert of diabetes and thyroid issues, which I love. I love reverse diabetes. And that's definitely something that even drew me into endocrinology to begin with, because when I was doing med peds and doing the pediatric half of the rotations and running to all of those deliveries in the NICU for gestational age babies, I was like, oh my gosh, what are we doing here? How can we improve care for diabetes? And why are so many women getting diabetes during pregnancy? When I then went into my endocrinology fellowship, I loved that aspect of the inspiration that you get from patients when, you think that diabetes is presented as this chronic, progressive disease that is lifelong and there's no hope. But what I love about our administration right now is that we're really changing the public health messaging around that and really helping people to say, hey, I can reverse this. And how do we get the whole healthcare system to embrace that we don't have to have these as chronic diseases that are going to lead us us to, terrible complications throughout our lives when you ultimately are forced to go on insulin. Not every patient with diabetes with type 2 needs to be on insulin. We can reverse that. You think about, as an endocrinologist, how you end up here at HHS doing this work in women's health, and to be in a place now where we can really change policies so that you think back on all those women who, in the end, we just want answers, and we don't want delayed diagnoses. We want information, and we don't want our symptoms diminished. If we have a symptom, we want to get to the bottom of it. And so being able to change that from a policy level has really been a dream come true.
That makes a lot of sense. But also, literally how? You were an academic doctor. Did you fill out an application form? Did somebody tap you?
Did.
Really? Is that what happened?
I filled out an application form. Yep. And
no way.
Yep. It's true.
Okay, so you the calling makes a ton of sense. And at one point you were the acting secretary before RFK Jr. was confirmed, and that's such an extraordinary shift in career.
It is, but public health has such an opportunity to really have that prevention aspect. And I know we talk about that a lot, but in the end, so much of the work we do is Band-Aid approach, right? And so that's what I love. And I mean, when you think about it, and a lot of times people, don't always appreciate the aspects of endocrinology with reversing chronic disease. And I think that's something that is in now the lexicon of public health, and we can never go back. And so being in the acting secretary and being able to set the department up to really start changing our approaches and really thinking about how can we, of course, we want to prevent, but unfortunately, we've done a terrible job of prevention, and chronic disease is rampant in our children and adults across the lifespan. I love addressing dogma. And I think that's also something where, when you're there practicing with your patients, you see them and you see what they really want. I have a very strong belief that we should, as, public health professionals, you need to be really connected to the front lines. And so I don't plan on staying in HHS forever. I want to go back to my patients, because you need to have your ear straight down to the ground, hearing from them, and they tell you what they want. You have to be on the front lines full time to really know the hormones of your patients.
Yeah, well, I mean, that certainly resonates with me. But just to land the call to action, if for all the would-be public servants out there, you too could fill out an application.
Yeah, absolutely.
Lead the women's health agenda.
Absolutely. And we welcome that.
The Office of Women's Health is something that not everyone might be familiar with. And my understanding is it was established in the early 90s, but not codified until 2010, which maybe is a statement unto itself. But can you help us understand just what is the remit of your office? Women's health is so potentially expansive. How does that office position within the government to get all these things done?
Well, it's a great question. And, I will tell you that before I applied for this position, I didn't even know the office existed. And that's the thing where there are so many people that are on the front lines of healthcare working so hard. And the government is just like this big box of HHS, of the CDC, and of the NIH and the FDA, but you don't know all the inner workings. And so there are a number of different women's health offices across the federal government. The HHS Office on Women's Health, which is through the Office of the Assistant Secretary for Health, is the office that I lead. Through that office, we're really closely tied with the secretary's team, and we really work closely across all administrations to get to the root cause of different areas of women's health and do pilot projects that ultimately can get transitioned off to one of the agencies to take them to the, billion-dollar budgets. We don't have those in OASH, but we do have the ability to say, hey, here's a gap. We need data in this area. Let's do work here. And if we can show what works, let's pass it off as a model that can work. An example of that is, when we first met, the maternal health crisis was really coming to a forefront in our country. I think what made me most frustrated about the conversation in general, though, across our country was it's all about, the U.S., it's the worst place to give birth. If you go to the hospital, the doctors are going to kill you. And what? This is impossible. I mean, I just came from hospitals where we have healthcare providers, the doctors, the nurses, the PAs, the front desk teams. And so I realized that we didn't have much data for what we were saying. And the data that we were talking about was 5 years old in some cases. And so how can we track a maternal mortality rate that is years old? And how can we develop interventions if we can't even see if they worked or not? So I said, I need data.
Right. It was just sort of coming into the public consciousness that maternal mortality maybe as the tip of the spear, was an issue for maternal health more broadly.
Exactly.
But we weren't systematically tracking what was happening across the country. And one of the accomplishments of the administration at that time was the Preventing Maternal Deaths Act and other things that we did to at least get to measurement.
Exactly. And so it's a lot when we're collecting the data. We appreciate all the work that states have to do and then how we report it up. But we can always do better in terms of getting women actual data so that they know that they're going to a hospital, that they're implementing the most up-to-date quality improvement bundles, and that we have real data behind the interventions that we're doing.
It was a shocking thing that moms today might be more at risk than their own parents.
Yes.
And so, of course, people want to understand why, and they want to know who to blame for it. I always saw it as more of a systemic indictment, but that's an abstraction for people, right? The people working in the trenches. I was one of them. They're people that are doing their best earnestly for people, but there are real gaps in the system. So as you then got the data years later now, what is it that you're seeing that implies a solution?
Well, what we did was we developed a collaborative. It's called the Perinatal Improvement Collaborative. And we have over 200 hospitals across the U.S. from every state. It's nationally representative data. Over time, we've collected baseline data, and then over time have worked with the hospitals to have them focus in on different aspects of quality improvement. We're still in the middle of it. And so I would love to, I'll definitely keep you posted as we have more, and we'll have more publications out in the coming months. But preliminarily, we have in the hospitals that are part of the collaborative, so over 220 hospitals, in the hospitals that have been implementing these interventions, we have a 41.5% reduction in maternal mortality during hospital delivery. So this is within the hospital, and compare that to a benchmark of a decrease of 5.9% in similarly situated hospitals over the same period of time who are not part of the collaborative.
It seems to me that so much of what's on your agenda right now is also broadly in the zeitgeist. Declining fertility rates, even the GLP-1 revolution, which demographically impacts women in all of the different ways that you described. So as you look out over the landscape and this limited window that you have to make an impact, what concerns you and what gives you hope?
The biggest concern is women not getting answers, women having delayed diagnoses, right? And when we think about infertility, for example, women want to know. And as I mentioned earlier, we talked about PCOS. Like, that is a leading cause of infertility. It is rampant. And what is the root core of PCOS? It's the new name, right? The metabolic side, right?
I think the name's actually a big deal.
100%. And I came across my desk yesterday. There was at the University of Colorado, there's an amazing physician scientist doing really great research with GLP-1s in young women with PCOS. And you think about how so many of them they're just told if you have painful periods, they're irregular, they'll get regular eventually. And this woman, this story from the University of Colorado, she talked about her story of how she was even diagnosed with bipolar disorder and put on all sorts of medications. And it turned out that she had PCOS. And once they diagnosed it and she went on a GLP-1, her life turned around. And so I do think that there's huge opportunity to address the chronic disease crisis in our country through many ways. And so that is me super excited, and just the whole paradigm shift in public health of truly focusing on prevention. It's truly incredible. The GLP-1s, also all the infertility medications. I mean, we're really onto something here, and we want women to know that there are options. And especially for infertility, like there's many paths. And so if you are struggling with, weight loss, and you have had irregular periods and you think you might have PCOS, now PMOS, talk with your doctor. There are many women, they say they got on the GLP-1 and poof, they're pregnant. They never thought that they weren't getting pregnant, and it happened.
Yeah, we see that all the time.
And so it's truly amazing to see. And that is what has me most excited with that woman's story from the University of Colorado. And I'm sure you've had those stories. I've had those stories. We want women to know that when they're having symptoms, they're not brushed off and they're getting those answers. And we will continue working to make sure that we have those.
Part of the complexity of your role is that it's never as simple as quality improvement in hospitals. There's like a complex system and you face all kinds of headwinds. One of them is an update to how pregnancy is going to be paid for, which isn't, in my view, like a headwind or a tailwind per se. It's just the fact that there's going to be a big change in payment coming at the beginning of the year. And historically, the way we paid for pregnancy care is with one fee for all of it. And some might say that's even a disincentive for the postpartum care afterwards, because all you get is this 15-minute visit 6 weeks later, and half of Americans don't even go to it. And so maybe under this new construct where it's more of an a la carte kind of payment system where you get paid per visit and you get paid for potentially longer labor, it certainly changes the incentives for care. And ACOG, the professional organization, lobbied for it. And so I think there's a way in which this works out well for obstetricians and maybe for the American people also. I've also been speaking with people on the ground who are concerned that maybe for rural Americans or for maybe even for just low risk people, there could be disincentives to provide good care. But I think all of that just sort of speaks to the complexity of the system. And I'm curious from your role, like how you're thinking about, you'd started to get into it with the TMAH model at CMS, but how are you thinking about payment as part of the solution here?
We want to explore all options here and keep working very closely with CMS as they're really thinking through the TIMA model and that value-based care.
TIMA, is that the inside baseball? Is that how you say it? TIMA?
Yep.
Okay, TMAH. If you're not an insider, you always say the acronyms wrong.
You're so good. And there's too many government acronyms. Don't get me started.
I like TIMA. That's a good one.
Yes, exactly. And basically, we want to be looking at value-based care. And so I really appreciate how they're working closely to say, how can we increase transparency, making sure that we have quality measures that we can really look at. And so I want to be open to say, how can we ensure that when you're going to see your OB, that they're coding so that you fully understand the complexity of the patient. And so right now, a lot of times we don't get the full picture because when it's all under one bundle, it's hard to say, was this patient, did they have all these other complications? And
as data people who are sitting here trying to make sense of it, you just get one code.
Right.
And you're missing all the granularity, right?
Right. And then it's also something too where, even I'll bring up my own case again, like when you're in the middle of pregnancy and then you end up having to switch to another doctor, you want to like give your OB a big hug and say, I'm so sorry I'm leaving, right? Because they've invested so much into you, yet the baby is not here. And it just creates a whole situation where, there are cases where you have to, switch doctors for whatever reason and moving or complexity, many other things that can happen. But when that happens, you appreciate all that goes on behind the scenes and how the care model, when it's just one large bill, doesn't really break down the complexities of care.
That makes sense.
You brought up a great point, and I really think that the postpartum aspect is where we can grow significantly with this because, if the baby is the result of the billing, like the baby leads to the bill, then what happens after the baby's here? And what are the incentives to have that follow-up and to check in, whether it's from a high blood pressure standpoint, from a mental health standpoint? And so I really think that this is going to enable doctors and the whole medical team to say, hey, your blood pressure was an issue. It could still be an issue. I need you to come back. Like, we're going to work together. And through the different models of telehealth that are now being promoted through the TIMA model and just in general across our country, hopefully we'll be able to have more visits that can lead to prevention that will ultimately then lead to lower morbidity and mortality.
That makes a lot of sense. I was actually at the White House under the prior administration, actually, when the TIMA model was announced. It was exciting to me that CMMI, which is the innovation part of CMS, was, I think, for the first time looking at maternity as an area to try and do something different. And, for whatever it's worth, my personal take is that the change in payment isn't automatically good or bad, but it depends on what we do with it. And ultimately what we collectively do to hold the system accountable for quality. And that's why some of the other things you're mentioning really matter. Back to addressing Dogma for a second. The professions, so ACOG, the American College of OBGYN, I have to imagine as part of that solution also, And I think, in many ways, you're a physician's physician and a clinician's scientist. And some of the administration's agenda aligns very well with that establishment community. For example, I think it didn't historically around the black box warning for HRT, but I think that was celebrated in that community. But then there are other things like the Tylenol part, which left that the profession, I think, scratching their head a little bit. And I'm curious how you think about your role and relationship with ACOG and how you think of them as sort of stakeholders and constituents as towards this agenda.
They're amazing, amazing doctors, researchers, clinicians. I mean, just an incredible group of people that we want to continue to work with and really think through how we can best support, whether it's the new coding and how we can make sure that the unbundling works for both the doctors and the patients, right? Just like you said. And when we're working with them and thinking through how we can improve care, like you said, with the black box warnings, it's an incredible moment for women. And a lot of times, so many of the announcements we do around women are for women of reproductive age, right? And that's, of course, like very important population. We are 100% committed to them. But so many times women during and after menopause are overlooked. And even when we talk about menopause, a lot of it's, are you within 10 years of menopause? Can you start the hormones? And so what I've loved about this administration's conversation about addressing the black box warnings and really looking critically at that data from, the early 2000s and saying, where are we now? Like, where do we need to go to make sure that women know their options and are getting the best care possible? And so it's always hard, right? It was the NIH led the Women's Health Initiative study. It's never great to have to, say, we probably, should have addressed this many years ago because generations of women have suffered. And so I really think that this is a huge opportunity for the ACOG community and also family doctors, endocrinologists like myself to really have conversations with our patients that when we've had them before, we've had so many roadblocks for our patients to get hormones. And what I love too about this is so many times we don't get the postmenopausal women included in the work we do. And so what I love about vaginal estrogen is that there's no timeline for it. You can take it when you're 40, you can take it when you're 100, and any time in between. And it can have dramatic impacts on your health in so many ways. And I mean, just think about the number of UTIs and urosepsis that we could save by women getting access to this medication that can work wonders for them. And so we are really looking forward to partnering with organizations.
That makes sense. I mean, the establishment's not always right, to your point on the Women's Health Initiative and HRT. And I think the profession has come around on that issue in a kind of radical way. I was at the ACOG conference a few weeks ago. And, a lot of the agenda was oriented more broadly to, if not chronic conditions explicitly, lifestyle medicine, which I think is a recognition that people don't just want to be not sick. They also want to be well. The president's panel was about it. And you'd probably be delighted to hear that almost every session on menopause and HRT specifically was standing room only. Like really, really different from what I've seen historically. And I think, again, like this is an area of great alignment. And also, there are areas where the relationship seems fraught right now. How do you think about when and how to push on either the establishment or the dogma? Because sometimes the dogma isn't just the idea, it's the institution also, while also trying to build that tent that brings in all the important stakeholders.
It is. It's a great question. And it's hard because, even with the HRT, the black box warning, I mean, all of that came from us, HHS. Like we have to own that. No one wants to own that. But you have to. And I think that for years, I remember when I first started, I thought, why have we updated this Women's Health Initiative study? And they're like, but it's the NIH's study. I'm like, I don't care. Like it doesn't matter what institution owns it. to our patients, that's who we're ultimately accountable for. And so it doesn't matter who came up with it. If we've, come along and, I totally respect, the Women's Health Initiative researchers, amazing people, and they did the best they could with the data they had at the time. But then once we have more data, we have to be able to take a step back and say, hey, here we are. And we have to be bold and not be, afraid or timid to say, we can change. When you think about like the dogma, like how many of us took on the black box warnings as if it was it was our job. It was, it was what we had. It was what was on the label. And so it didn't just become the dogma of the NIH. It became worldwide dogma. It wasn't just stuck in the US, And so I just share that to say it's hard when you've done something one way for so long, and that's just the way it is. It's hard to think about things differently sometimes, but I always go back to, I think, like to the patient, right? And that's what I said. We need all of HHS to be back seeing patients every few years, right? So that they don't forget that important aspect of like, what do patients really want?
Thank you again so much for your time. Thank you for your service. Thank you for being so accessible.
Oh, absolutely. And please know, and with anyone you come across, or we're here to work together. And there's so much research that we need to continue to translate out there so that we can make the biggest difference possible in women's health.
Well, we certainly support that vision and look forward to the progress that we make towards that reality.
Great.
Thank you. That was Dr. Dorothy Fink. She joined the federal government because in clinical practice, she saw there were many things that didn't make sense, and she wanted to be part of the solution. Here's the thing. I've seen over and over in my career that a bad system will beat a good person every time. And that oftentimes when things don't change, it's not the people working in the trenches that are the problem. It's that they're up against entrenched interests. Dr. Fink said that challenging dogma was a big part of her motivation. And I think that challenging dogma is a good idea, especially in these times. It's also important, as she said, that we invite all the right stakeholders into the process and that we make decisions that are anchored in science. And now for our required reading segment. Dr. Fink and I just spoke about the complex policy infrastructure in our country that both supports and doesn't support families in this country. My required reading for this week is about the other side of the story, and it's about the families themselves. About a decade ago, very few people were talking about maternal health or maternal mortality in our country. And what changed the national conversation was incredible investigative journalism. Nina Martin at ProPublica and Renee Montaigne at NPR started to go to Facebook to source stories about women and their families who suffered the worst of our healthcare system. And they created a series called Lost Mothers, where they put faces on the names of people who suffered from maternal mortality. They described the story of Laura Bloomstein, who was a neonatal nurse. She spent her career keeping other people's babies alive in the hospital where she would eventually die after giving birth to her own. They told the story of Kira Dixon Johnson, who was a person who spoke 5 languages and started businesses and was just this force of nature. And despite all of that, hemorrhaged for 12 hours at a premier hospital in Los Angeles without people paying attention to her needs, even as her family was advocating for her. They tell the story of Shalon Irving, a commissioned officer at the CDC whose literal job was to study structural inequity. She was an expert on the forces that ultimately killed her. And these are all gut-wrenching stories that are told unflinchingly in this journalism, and they led to a sea change of advocacy and even federal policy, including the U.S. government's Preventing Maternal Deaths Act that Dr. Fink and I talked about. I'll link the full piece in the show notes. I would strongly recommend reading the whole thing. It's so powerful. Thank you to Dr. Fink for joining us. If you found this useful, share it with somebody who needs to hear it. New episodes drop regularly wherever you listen. I'm Dr. Neel Shah. This was The Preprint. We'll see you next month. The Preprint with Dr. Neel Shah is produced by Maven Clinic in partnership with Pod People.